Production and distribution of City Club forums on IdeaStream Public Media are made possible by PNC and the United Black Fund of Greater Cleveland, Incorporated.
Good afternoon, everyone, and welcome to the City Club of Cleveland, where we are devoted to creating conversations of consequence that help democracy thrive. It is Tuesday, December 10th, and I am Ken Schneck, editor of the Buckeye Flame, Ohio's LGBTQ+ newsroom, and the moderator for today's conversation, which is sponsored by the AIDS Task Force of Greater Cleveland and is also part of the City Club's Health Innovation Series, sponsored by Medical Mutual. It has been more than 40 years since the onset of the HIV and AIDS epidemic in our country. And those who were some of the first to be diagnosed are now entering their retirement years. Thanks to extraordinary advances in antiretroviral therapy and support services, survivors are now living long and healthy lives. For this reason, more than half of people diagnosed with HIV in the United States are aged 50 and older. Now, because of that, researchers, doctors, and patients are once again facing questions with uncertain answers on what to expect from HIV and AIDS in aging bodies. And yet, despite many medical advances, a stigma around the virus remains, as do outdated laws and policies targeting the HIV and LGBTQ+ community. Here in Ohio, 6 of those laws are still on the books and have been actively used to prosecute hundreds of Ohioans over the past few years. So, where are we now? What work is being done to understand what it means to age with HIV and AIDS, and what services and expertise are needed to understand better what it means to age with the virus? Joining me to discuss this right here on stage, right to my left, Kimberlin Dennis, an author, motivational speaker, and founder of Ministry of Hope. She is a 15-year survivor of both HIV and breast cancer. Right to her left, Gil Kudrin. Oh, yeah. You're going to have to do that now after each one. You just set the standard. Gil Kudrin is the Chief Executive Officer of Nightsweats and T-Cells, a clothing line that promotes strong and positive messages about HIV and AIDS. He is a long-term survivor of HIV and AIDS who has spent his life volunteering for organizations like the Ohio AIDS Coalition, ACT UP Cleveland, and with dozens of legislative efforts. And also here is Dr. David Margolius, Director of Public Health at the City of Cleveland, previously serving as the Division Director of General Internal Medicine at Metro Health. He brings a wealth of experience to the role, along with a deep understanding of the impact of Cleveland's social determinants of health. If you have a question for our panelists, you can text it to 330-541-5794, and City Club staff will try to work it into the Q&A portion of the program. And now, more officially, members and friends of the City Club of Cleveland, please welcome our guests to the stage today. Okay. So for a conversation like this, I thought we could take a walk through the past, talk about current successes and challenges, and look towards the future. So let's start by taking folks back a bit. This is reliably an intergenerational audience here at City Club that doesn't always know what communities have experienced in the past, particularly in the 80s and early 90s. Kimberlin, let's start with you. How do you describe that period of time with regards to HIV and AIDS to folks who just didn't live through it?
Well, first I'm a 30-year survivor of HIV/AIDS and a 15-year survivor of breast cancer. But I remember in the beginning when I was diagnosed 30 years ago, my husband was diagnosed first with full-blown AIDS. We didn't know anything about HIV/AIDS, only what we heard through the news media with Ryan White and hearing Magic Johnson tell his story in 1992. So we thought this was something we didn't have to worry about. And my husband contracted lesions And they started and went over his whole entire body and ended up in the hospital. And they found out that the HIV/AIDS, they gave him the HIV/AIDS test, was the last test that he did because we didn't fit the category of HIV/AIDS. So when he was diagnosed with full-blown AIDS, and he lived 3 months after being diagnosed. Back then, people were dying so fast. You didn't have time to get any insurance or get any life insurance or get your stuff in order. So it was devastating for us because we were married 7 years and we were, newlyweds really. And we were planning funerals was nothing on our mind as far as getting a will or getting, our plans in order. So just seeing the devastation of people dying so fast and being told that they only had weeks, months, maybe a year to live with this disease, it was very devastating for me. So.
Thank you. Gil, how about for you? Is there a story that comes to mind in just describing what it was like during that time to folks who might not know?
Yeah, it was everyday life for me because I worked at Lakewood Hospital. I started there in about 1977 and worked there through 95. So at the beginning of HIV, I was like the fly on the wall. All the horror stories that you heard going on in hospitals and the uncertainty and the fears in treating people. And I knew by 1981 I had been sick already for 3 years. And I knew that I was HIV positive when we heard the news about HIV. And so I just had to negotiate my life as a very young man, 23 years old, knowing that I probably didn't have long to live, and watching how people would care for me when I did become ill, or not care for me. It was a frightening time for young gay men or anybody in the gay community, and I literally, through the 80s and 90s, watched over 200 people from my community die. Sometimes very long, drawn-out deaths, sometimes very fast. So it made me appreciate being alive very, very much.
Yeah.
Still do.
Yeah. And Dr. Margolius, what about the medical community at that time? I have to imagine that the lessons learned were just endless.
Yeah, so the first cases were identified by the medical literature in 1981, but as Gil said, it had been already 3-4 years that people in the United States at least had been infected and been dealing with this. And then it was another 3 years before a virus was identified, and another 5 years, it was 1986 that the virus was first named. So imagine, everything we went through in March 2020 with all that uncertainty until we had tests, which was, weeks, but felt like years. This really was almost a decade before just knowing what the disease was that was infecting so many people. And not till 1987 that the first meds existed, which weren't very good. And not till 1997 that there was the first effective treatment, truly effective treatment that was made available to everybody.
Let's bring it a little bit into the present and really dive into talking about aging with HIV. Gil, give us a sketch of some of the challenges that individuals are encountering these days.
I'm old. It's a challenge for everybody who's old. For us, it's a little different. One of my biggest challenges is having been HIV positive from such a young age. We in the HIV community turned ourselves into medical researchers because we were not high up on the list of our nation's government of people to look after. So we had to form our own organizations, a continuum of care that would take care of our friends who were dying and then be in place for ourselves. And what I find now is that a lot of young doctors, a lot of young nurses, even the more experienced ones, if I go in with a medical problem, some people still don't want to treat you, not because they are afraid of you, but because they think they don't understand the medications that you're on. So if I present at I just get the flu, and I go to a local CVS or some minute clinic, the person who would prescribe antibiotics is like, I don't know how this will work with your medications. I don't want to do that. So there's that barrier to care for us still. And then there's, that a doctor will look at us and say, oh, well, your T cells are high, your viral load is undetectable, so you're pretty much okay. So when I experienced COVID, I got, it seemed to be an early adapter to plagues. I got sick very early on. I was sick for 10 months. And one of the things, I developed rapid onset scoliosis, which usually only happens to adults in refugee camps, but because of malnutrition. And I had dropped down to about 140 pounds, and my doctors were looking at me, and I said, I want to get on human growth hormone, because I think I'm experiencing what we did back in the day when people would have what we called wasting syndrome. And my body, I was eating 3,000 to 5,000 calories a day, and I was still losing weight. My body would not absorb nutrition, but my T cells were good, and my viral load was undetectable. So I went untreated in a way that I should have been, I think. And later on got an apology and said, you and your partner were probably right, but I still have serious scoliosis because of it. So
I want to remind everyone, all of us are in our early 30s here on stage. So when he says old.
Okay.
Kimberlin.
Yes.
Yeah.
Well, I remember the first medicine, AZT. And I remember how it not only had an effect on me, but also with my husband. I thought he was taking it, but when he passed, I realized he wasn't taking it. In the beginning, it seemed like our health was going backwards instead of forwards. And I had a hard time adjusting to that medicine, and not only that, other medicines. I stayed sick all the time and trying to find the right medicine. And then that's when I realized that the clinical trials were only done by men. And then I realized, okay, I'm a woman, and they was also giving the same medicines to babies as well. And I said, I'm not a baby, I'm a woman, a female, and I'm not a male. So that's what got me involved in clinical trials. And then I realized too, over the years and taking the medicines, everybody's body is different, so the medicine reacts to everybody's body different. And in my case, I had to go through almost a 2-week period for the medicine to get in my system in order for it to kick in and start reacting the way it was supposed to react. I know a lot of people gave up within that 1 or 2 weeks taking medicines, and it made the situation even worse. And once you stop taking a medication, or you're on a medication and you're not taking it, it disagrees with your system, then you have to find a new medication. So I stayed on my regimen for a long time. I recently just changed my old regimen in the last 3 years and started taking Biktarvy. And the only reason why I changed my old regimen, I didn't change it, but they made me change it because the pharmacist stopped selling the medicine. They wouldn't make it anymore. So that's the reason why I'm not taking that particular medication. But I'm seeing the response of how it not only affected me, but affected a lot of people that was taking the medicine as well. We dealt with a lot of situations with, humpback and different areas of fatty tissue growing and losing weight. I went down to 90 pounds, a person that weighed 130, 35 pounds. I went down to 90 pounds, and trying to pick that weight back up again was very hard, and still is. Being able to eat right and taking my medications, the importance of taking my medications, importance of knowing that if something attacks my body, a cold or flu or anything, that I have to stay on top of it early, because if I don't, in my situation, my cold will turn into pneumonia. I've battled pneumonia I don't know how many times and not trying to get it again. Even as a child, as a baby, I had it 9 times, my mother said. But the last time I had pneumonia, 15 years ago, my mom passed. while I was in the hospital battling pneumonia. So I keep up on my immunization shots. I make sure that I take good care of my health, the importance of taking care of my health, and just trying to stay on top of whatever that's going on in the HIV community as far as updates on clinical trials, updates on medications, updates on support, updates on practically anything that could help with my health, because it has to start with my mental state first before it can actually help my physical state. So I work on both parts, mentally and physically, and staying healthy as best I can.
Part of our current context that we talk about in healthcare is a shortage of primary care doctors. Dr. Margolius, can you talk about the intersection of that shortage and today's topic?
Yeah, so for years before joining the Cleveland Department of Public Health, I was a primary care physician at Metro Health, and I had a panel of about 1,000 patients. So there'd be 1,000 people in the Cleveland community who said, that guy's my doctor. And every time I'd get a new patient, there's this dance, and I think many in the audience will know that dance. It's, you get there, you've got your list of medicines, your medical history, and you're wondering if this doctor is going to be comfortable to continue those medicines, or if they're going to come up with something new, if they're going to mess up what's already working for you, or if they're going to find something new about you. And for someone living with HIV, that's just so much harder, because you're meeting a new doctor wondering if they're going to be comfortable with your diagnosis, or if they're going to refer you to 6 specialists instead of just refilling your meds as your previous doctor had always done. And so that's exacerbated by a national shortage, because fewer and fewer doctors are going into primary care because of the lifestyle, because of the salary, because of the way med students are taught in med school to want to be uber specialists instead of general doctors. And so as folks currently who were diagnosed with HIV in the 80s, 90s are aging into this more senior demographic, it's just going to be really challenging to find enough good primary care doctors to take care of you.
When we were all on Zoom last week, Kimberlin, you said something that I can't stop thinking about how stigma is still present, which I think we all know, but that it has evolved, that it looks different than it used to. Can you talk a little bit about stigma as it exists right now?
Yes. In the beginning, when I was diagnosed 30 years ago, the stigma of this disease was very prevalent in the community of people not wanting to show you love, to touch you, to kiss you. They thought it was all these different ways you can contract HIV. People were afraid of you, including the doctors, because I've been discriminated in the hospitals, I've been discriminated in the community, I've been discriminated pretty much in a lot of places. And so dealing with that type of stigma today, for me, being an advocate in the community and seeing the stigma now of people living with this disease, afraid to still disclose for whatever reason, afraid to get involved, because of stigma, and these are a lot of reasons why they're, so the stigma today is totally different from the stigma back then. The stigma back then was about, okay, us being positive, people afraid to be in your atmosphere or afraid to be around you. The stigma today with this generation is who knows, or who I don't want to know about my situation or talk about my situation. I can't tell my friend, I can't tell my parents, I can't tell my children for whatever reason. And it's causing us that's living with the disease to hold on to the stigma that I feel that if we release it and just step out and allow us all to come together on one accord, like it was back in the early days with ACT UP, and people weren't afraid to, to be involved, to get something done, to fight for the cause, maybe we will be further along than where we are. We've came a long way as far as with medications, as far as with education, as far as with information. We've come a long way, but I think we would be able to go even further if the stigma of that, because being a survivor of breast cancer for 15 years, like I told you, I can go out into the community and I can talk about breast cancer, and it's just people love on you, they care about you, and I see this not only in the community, but in my own church home. I give programs there for World AIDS Day and for breast cancer, and we pass out pink ribbons in October. Everybody want a pink ribbon, everybody is involved, but when it's World AIDS Day, and you try to hand them a red ribbon, it's like, oh no, or they'll take it and they'll put it in their, put it up, they'll put it in their purse or in their pocket or something. So that stigma is still there, which is sad. You're not gonna contract HIV for wearing a red ribbon or acknowledging a person that has on a red ribbon, but just for people wearing a red ribbon, people are thinking, oh, this, I'm in this community, or I'm a part of this organization of people dealing with HIV/AIDS, so I'm not even gonna put this red ribbon on. So that particular stigma to me today is alarming, that people still have this new type of stigma that I call it. So.
Yeah. All right, let's talk about the future. Gil, I know this is one of your favorite topics to talk about, the election. The election could have truly consequential effects, not just for all of society, but certainly for HIV and AIDS care. Can you talk to us a little bit, Gil, about the Ryan White CARE Act funding and the connections between that and politics?
Yeah, it has always been political. The response to HIV was a political response. There's a book written by a doctor, I think his name is William Clark. He was out of Florida, and it's AIDS in the Eras of Pestilence, and he looked at historically what societies have done in times of plague, and we have a long history through artwork, of which I still do around plague. And for the first time in the history of mankind, we had a plague and society did not respond. They didn't care. I oftentimes now thought I was going to settle back and not be active in the politics around HIV, but my very life depends on it. The Ryan White CARE Act was passed in 1990, I believe, and it puts together all of the federal funding for people with HIV and AIDS in the United States. Cleveland was very hard hit early on by HIV because we had a big gay community and we had a really important gay bar in the country. Trax was one of the top 10 discos in the United States. So I got involved, the Ryan White CARE Act money came, I got involved with that because I was involved with ACT UP. And the Ryan White CARE Act was emergency funding. It was funded for 7 years. It sunsetted after that 7 years, and it had to be reauthorized. People in both parties decided that HIV was not important enough to pay attention to. And the Ryan White CARE Act was never reauthorized. That funding is now discretionary funding. Project 2025 refers to Ryan White CARE Act. I've read all 950 plus pages of vile garbage from them, and it refers to Ryan White CARE Act as funding for transgender surgeries and care. And I was on the priority setting committee in our local Ryan White council for 14 years, I think, Kimberlin, and never did transgender care come up at all. It's for HIV medications and care. But they have made it very clear that they want to cut this spending completely. 500,000 Americans with HIV gain access to their medications through the Ryan White CARE Act. It is, in my belief, very likely that by the end of January, and certainly by March 1st, which would be the beginning of the Ryan White fiscal year, that we will see the program eliminated completely. They have made their intentions very clear that programs that are not authorized, but spending is still happening, is where Elon Musk and Ramaswamy are going first to make cuts. Gay people are certainly on their list. They want retribution for my survival. They don't simply want me to go away. They want me to suffer before I die. And the best way to do that is to take away my meds. When Mike Pence, I wrote a white paper for the RAND Corporation when Trump was first elected president to look at what were the possible cuts that could happen. And you can Google this. The people at RAND asked me after conversation to put everything down on paper, to reference it, and Mike Pence was asked about reauthorizing the Ryan White Care Act when he was in Congress. And he said, I don't get it. Why would we spend all this money on medication for these people? If we don't give them the medication, they die, right? And the reporter said, yes. He said, then the problem will be done, right? You can Google that. And he's kind of a nice guy compared to these people. So I think there is nothing that isn't political about my survival. Larry Kramer used to say, just being a gay man today is a political act. They didn't spend $250 million to just come after trans people on ads. They're coming after my meds. All that stands in between me and them is you.
Part of survival, too, is making sure that our healthcare providers are trained and that we're eliminating stigma there. Can you talk a little bit about how we can make that training happening, how much more training is needed?
Yeah, I mean, when I was in med school, some of these medicines were still being developed. The treatment at the time was, if someone with HIV came into your office, you'd wait to start treatment until their T-cell count got to a certain level, or their viral load was high enough. And so we've come a long way. Now, U equals U, undetectable equals untransmissible. It's a single pill once a day. And so HIV is taught in med schools as a routine thing, which is how it should be taught. Now, on the flip side, because of the politics, we need to think of it as routine and opt out and just another test that you'd send when someone gets in the hospital. I think recognizing that history, everything that Gil and Kimberlin have been through, have fought for, is a really important context for today's healthcare workforce, so that this doesn't happen again and so that we can fight back.
One more question for all three of you, and then we'll turn it over to question and answer. I tell anyone who will listen that there is no greater, more powerful elevator pitch for establishing a sense of urgency than silence equals death. There has never been a more iconic and critically important slogan. What do we need to be shouting about? What do we need to be yelling for everyone to hear with regards to HIV and aging right now? Start with you.
Well, first, it's not a death sentence. So people are living longer. We're aging with HIV and AIDS due to the medications, due to a lot of support, and due to funding and Ryan White services and stuff. So I just want people to know that I commend each and every person that's involved in this fight, because it takes us all to win this fight. And so anyone that's here that's or available to roll their sleeves up and get involved and try to do whatever part they can to help in this epidemic, that's my shout. To shout it out to the world that we need all hands on deck. Because I don't want to see it going backwards. I want to see, for being positive for 30 years, I have seen a decrease in newly diagnosed people, but people are still being newly diagnosed, which is not as alarming as it was in the beginning. But as far as the stigma piece, I want to see a large shout of that. I think we can move forward in greater numbers, and people that don't want to disclose their status for whatever reason, is other places that they can do the work, far as calling your councilman person or your legislature or sending out letters, or you can do stuff behind the scenes. In other words, you don't have to always be in the forefront, because it's not very few people like me and Gil that chooses to show our face in the place, in other words, and be out on the forefront, which is fine, but like the Bible said, all the parts are important, so each one of our part is important in what we play in making a difference in the community and fighting for what it is that we need and we want and getting answers and getting it done, because it's taken a long time. I've seen so many infectious become with a cure or have a vaccine, and here it is with HIV, we still waiting, so I'm truly hopeful that I will survive the cure and live it, and probably be in somebody else's platform talking about it. So,
Give us one thing to shout about, Gil.
The National Institutes of Health only spend 5% of their budget on finding a cure for HIV, of the HIV money that they have. They spend most of their money trying to repackage our medications in a new delivery system. But they're basically the same exact medications we've been taking since 1997. I think we have, a couple rescue meds for those of us who've run through everything. But I think, Julie Patterson earlier just touched on the most important thing. We have the tools to stop this. We do not have the political will to stop this. In Sydney, Australia, they have taken HIV off the list of public health concerns because they got everybody who was positive treated, they got everybody who was at risk on pre-exposure prophylaxis. If you take, and I put this into my speaking gigs when I spoke for the infectious disease docs at Cleveland Clinic in their grand rounds, is if you look at COVID and you take by zip code the COVID deaths, and you overlay that epi data with the new HIV infections in this country, you will see that those zip codes correlate almost perfectly. Because it's mostly young black men who have sex with men, or a big part of the new infections, and people do not care about them. This is about hating gay men. This is about hating black people. This is political. Everything about this is political. I've been doing the silence equals death version of the shirt, Larry, and I worked on many projects together, but I did one on my own that, to me, my parents marched in the civil rights marches in the 60s. And Martin Luther King said the same thing. He used different wording. There comes a time when silence is betrayal. You have betrayed us. Our country has betrayed us. We could stop this today.
One thing.
Yeah. And also, good luck following that.
You're right.
Yeah.
Yeah. So in Cleveland, about 100, 140 new cases of HIV every year. And Gil described the population that's most affected: young black men who have sex with other men. And their population, particularly young black men who have been neglected in the city, and women, they are here. They've been completely disenfranchised through all the COVID lockdown and virtual and stay-at-home stuff. We screwed up and really locked out a lot of families out of Cleveland that have not come back. They haven't left the city, they just haven't re-engaged with our systems because our systems betrayed them. And so that one thing is we've got to earn that trust back. We've got to figure out how to solve poverty in Cleveland and earn trust with our most disadvantaged communities here.
We're about to begin the audience Q&A. For our live stream audience, or those just joining, again, I'm Ken Schneck, editor of the Buckeye Flame and moderator for today's conversation. We are discussing what is being done and what is needed to better understand what it means to age with HIV and AIDS. Joining us are Kimberlin Dennis, an author, motivational speaker, founder of Ministry of Hope, and a 30-year survivor. Gil Kudrin, chief executive officer of Nightsweats and T-Cells, and one of my gurus. And also here is Dr. David Margolius, Director of Public Health at the City of Cleveland. We welcome questions from everyone, City Club members, guests, as well as those joining via our live stream at cityclub.org. If you'd like to text a question for our panelists, please text it to 330-541-5794, and City Club staff will try to work it into the program. May we have the first question, please?
Hello. Our first question is a text question. It says, how prepared are our nursing homes here and around the nation for residents with HIV?
Great question. Who wants to take that one?
I just helped a friend move into assisted living recently, and actually at the beginning of COVID, he was living by himself, but had ended up in a nursing home for a short stay in theory because he had a bunch of respiratory infections. He probably had COVID. It was January and February of 2020, and he ended up having to go home to his family's home and now just moved into long-term care. He happens to be a black man as well, and he's been living with AIDS since the very early 80s. He got pneumocystis at the very beginning of AIDS, and he somehow has survived all this time. The nursing homes are not prepared. They're not prepared for anybody, right. Much let alone somebody with AIDS. Right. Assisted living is not prepared for anybody. We are too busy building more apartments and townhomes for rich people in the city. When was the last time we did any serious affordable housing? We certainly have no affordable health care for aging people in Cleveland or anywhere else in this country.
Gil.
Great. Hi. Thank you to the City Club for this forum. Being diagnosed back in 1988, I literally never thought I would be at a forum on HIV and aging. Like Kimberlin and Gilbert had mentioned previously, when we were diagnosed, you got 2 years, go home and get your papers in final order. So here we are, senior citizens with HIV. A statement and a question. A statement to Ken. You asked, what should we be yelling about? We should be yelling about the comorbidities that aging with HIV is bringing. Comorbidities such as stroke, heart attack, broken bones, things that others think that, oh, well, you're just getting old. Like, no, I'm 40 years old and I'm diagnosed with osteoporosis. That is not in the, quote, normal realm of things. So that's what we should be yelling about. My question goes to the doctor, is since an individual at intake with his or her HIV physician is immediately put on a statin as the standard of care, should we also get a baseline neurological exam, HPV, HPV, hepatitis B, C, and D screening, neuropathy screening, frailty, bone density scans, and a pre-screen for osteoporosis. And all of these that I've mentioned are, when entering care, and this is my personal experience, is that I received a baseline some years ago, and then we have another of these series of tests done to see here's where you were and here's where you are. Do you see this as being integrated into intake? Personally, I think it would help the physician and the client, because then the client can plan ahead. The physician can also say, well, you know, we see your bone density as a XYZ 5 years ago, and now it's like here, and it's dangerous. And this is coming from someone who I'm in stage 3 kidney failure. So if we would have known earlier, could things have been addressed better? Like I mentioned, since we know entering HIV care, your standard of care is now you're on a statin. Should these tests also be part of that standard of care, especially with someone who's older and entering the HIV and aging therapies?
Yeah, so thanks for that question. So, with anybody going to your primary care doctor, there are a number of screening tests that they could order based on your risk profile and based on what we can do with that information. There are some people who will come to my office and say, I would love an MRI of my brain. I just want to know. I want to see how it progresses over time. And there's not a lot we can do with that information. And so for each screening test that you described, the question is, what do you do with that information? Would it change treatment? And if the answer is yes, then absolutely it should be part of the guidelines and part of the standard of care. And there is a lot of things that we don't know for treating someone, taking care of someone who's been on HIV medications for a long time. We think the medications are getting safer and safer, but there's nobody in the world who's been on Biktarvy more than 10 years, right, at this point. And so we're still learning, and that's why funding for the science is so important.
Thank you.
Hi, my question is for Gil. Gil, first of all, thank you for reading over 900 pages of that. So I have two questions. First of all, I want to learn more about your clothing program. And then also, you talked about the medications being at risk of the program ending or so can you tell us a little bit more about how it's in the transgender section where it's being taken away, why it hasn't been reauthorized, and what we can do as Cleveland people to, stand up for that, and what you're doing for that, and how others can be involved with that.
Okay, so first off, night sweats and T-cells. I've been involved with night sweats and T-cells since 6 months after it started. We don't just do our own line of clothing. We employ people with HIV, and we supply custom screen printing for organizations like Broadway Cares, Equity Fights AIDS. We've worked for Adobe. We've worked for Bernadette Peters, for Lin-Manuel Miranda. We do the Columbus AIDS Walk shirts, the Cleveland Pride shirts, and we've employed people in Cleveland. We just started our 35th year last month. We have never had a penny of funding from anyone. We are just a small group of people with AIDS who put this program together, and we wanted to help ourselves and our friends with HIV so that we didn't have to make decisions between buying AZT and buying food. The risk of the funding. So the only place they refer to the Ryan White Care Act in Project 2025 is they refer to it as transgendered care, because they are trying and have very well equated anything that helps a gay person with transgendered care and coming for your children. We're the boogeyman. We've always been the boogeyman. Jesse Helms, Ronald Reagan. Ronald Reagan didn't even say the word AIDS for 7 years. How are they going to cut it? Well, I can tell you for free that nobody in either party cared enough to expand the political capital to protect gay men year after year after year, and that's how people view HIV. They don't see Kimberlin. They don't associate Kimberlin with it. They associate me with it. When Ryan White was diagnosed with HIV and it became public that he had AIDS, Ryan White went to school, and he, either Ryan White or his, when he went back to school, and I've talked to Ryan's mom about this, he got back to school and his locker had faggot written on it. He was a little boy. His hemophiliac. When I was putting together the resource guide for the Ryan White Planning Council in Cleveland for our 6-county area, I did research into every service that was offered. Night Sweats and T-cells was contracted to do that. And I looked at every service that was offered in our 6-county area, and I contacted the Hemophilia Society. And I said, you know, what HIV services do you offer? They said, none. I went, none? I said, no. Hemophiliacs die so fast with HIV that there is no services necessary because they had such massive infusions of many, many people with different strains of HIV poured into their bodies at once in the clotting factor. So, you know, the proverbial face of AIDS was still this gay man that, you know, now they're coming for us. There is nothing politically, you could say that the courts will protect us. The courts are clearly compromised. In the state of Ohio, most Ohioans do not know this. Something that you could do now, you could lose your mind today just doing what you need to do in your own backyard. The state of Ohio in the budget in 2021 passed a part of the budget was passed that any medical professional does not have to treat a gay person if they find them offensive to their religion. So I get cut, ambulance shows up, I have to by law tell them I'm HIV positive. We have the most archaic HIV laws in the country in Ohio. If I do not tell them I'm HIV positive, I could go to prison for attempted murder. I can be prosecuted. If I tell them I'm HIV positive and they decide they hate gay people and their religion really doesn't like gay people, they can get back in their ambulance and drive away, and nothing can happen to them. And Governor DeWine acknowledged that he could have line item vetoed that in the budget, and he acknowledged that he chose not to do that because it was more important to not offend religious liberties than to provide care.
And I always take
and that puts Kimberlin at risk,
right,
as much as me.
I always take this opportunity to highlight, especially when that Medical Conscience Act comes up, it also disproportionately affects our rural siblings who don't have the option of finding another provider as they might in the Cleveland area.
We have another text question. What policy changes would have the most immediate impact on improving care for older adults with HIV? And how can policymakers be encouraged to prioritize funding for age-related HIV programs?
Policy change? Well, they need to first acknowledge that the care is needed and not cut the funding that's needed for the care. And we can't be long-term survivors or survive if we don't have the proper care that we need. Medical, you know, as far as medical insurance, we need the proper medical insurance. We need the proper medicines. We need proper care as far as with doctors. And so that they need to acknowledge that, and then the expense, the cost of medical. You know, a lot of people, you know, trying to have affordable medical care is important. So we need to, our county need to acknowledge, and the political people need to acknowledge that the importance of care is important for all people, not just people with HIV/AIDS, for all people, the importance of care, because in my health care, I have other issues going on. And if I choose to not be able to take my diabetes medicine because I need that more than what I need for the cancer, the breast cancer treatment, then I'm cutting back on my own health. Thankfully for Ryan White Services, my HIV medications are being taken care of, but we still need that funding to be able to have people into care, and the importance of care is our future, is our health, and keeping us surviving and thriving.
And we tend to live in greater poverty. Anybody with chronic medical conditions in this country tends to live at the edge of poverty. So one of the housing solutions that I found most interesting in the country was for chronically homeless people, and we see kind of a small version of that at the Y Haven in Cleveland, but in San Francisco, an amazing breakthrough with having kind of a dorm-like setting for people who were at the risk of being homeless, because As you get older, you don't want a lot of space to clean or to take care of, and a kitchen down the hallway and a fridge in your apartment might be what you most need in a community. As you get older, that community becomes smaller and smaller for everybody.
Right.
But for people with HIV, it becomes, you know, my dating pool is a puddle. I'm 66 years old, and over half of my contemporaries died in the 80s, in the 90s. So, you know, the community is a huge part of it.
Well, I'm 63 and I still have problems
You're
with
still
that.
in the puddle,
I'm still in the
too.
puddle, too, so.
Our dating forum will be next week. Totally different topic. Yeah. Thank you.
Thank you. And thank you to the panelists for having the ability and desire to get in front of this group and the audience outside of here, because I grew up in an era where you would have been ostracized for doing this. You brought up earlier the issue with nursing home care for the aging population. I faced this with a 27-year-old patient in 1989. No one would take him. He had end-stage illness. 3 nuns came from a convent and offered to take him in. He lived with them for a year and a half. We need to have more of this kind of care for the HIV patients. Number 2, people who want to read more about this kind of a topic, from a novel written, it's called Uncharted Territory, about a gentleman, older gentleman in Wales who had HIV, developed frailty, a lot of terminal illness, and required nursing home care. And it's about the journey this man went through trying to get into a nursing home and be cared for. We've talked about several things. We haven't touched on psychiatric care for HIV people. Talk about depression, loneliness, and being isolated. Gil has faced this. You have as well, Kimberly, losing so many friends over the years. How are we going to get more psychiatric care for them? How are we going to keep more medications available? There are, as we have said time and time again, the means to end this epidemic, but we have to come up with the means to keep these medications on. The current administration was able to decrease the price of multiple medications. Let's see if we can push them for HIV. So I think this is perhaps one area where, if you agree, we should be advocating.
Yes, I agree. Being a person that's a widow, stay by myself, no children, you know, I worry about aging, and with HIV, I didn't think that I would live 5 years after being diagnosed, and here it is, 30 years. And even in saying that, I don't want to be in a nursing home, but if it comes to that care for me, I prefer it being taken care of ahead of time now, because we are aging with this. And there are older people, like you said, 70s, in their 70s, that's battling this disease. And it's alarming that that the system needs to be more educated, and not only just in the nursing homes, but in the hospitals as well. Because I had to transition from one hospital to another due to my medical care, my medical insurance. And in doing that, all my new doctors that I had to deal with this year, I had to educate them on HIV/AIDS. You know, it's like, okay, you don't know about Ryan White care, you're not educated on this. It was alarming to me. We have a lot of young adults, students, there's new doctors and stuff, and it's like, the education needs to be back in the hospitals, and we need more education and more care for the nursing homes as well, as far as us aging with this disease.
In early years, our HIV doctors, our specialists, acted as our primary care doctors because nobody was going to live long enough to, so I know you know this for sure. I lost my doctors to, my first doctor, John Terry, died in a horrible accident And then I went over to Cleveland Clinic and had 26 years with Dr. Susan Ream, who was one of the most amazing physicians in the world. And she retired. Her partners in the practice also retired. So let's start with new doctors.
Yes.
26 years in, towards the end of my life, and the newer doctors don't know my history, don't know the fight that we fought. And it was the only good thing I saw in Project 2025. I can tell you there was one good thing, was that out of 950 pages, and it was a loophole for them to steal more money, but God bless. One of the problems with there are many talented therapists who are not necessarily mental health therapists, who are not necessarily associated with hospital systems that are in private practice that could see more patients, especially now that we have, Zoom technology. I see a therapist and we do it over Zoom. But my therapist could never get reimbursed from Ryan White Care Act dollars or a lot of public health dollars because she is not associated with a hospital. She's not in a hospital. So that care of, she can provide less expensive care to a patient like me, but she can't get reimbursed through a lot of public health programs.
We know there are so many more questions and so many more topics, but we have remarkably come to the end of our time together. Certainly our thanks to Kimberlin, to Gil, to Dr. Margolius. I promise we will applaud you in just a minute. Forums like this one are made possible thanks to generous support from individuals like you. You can learn more about how to become a guardian of free speech at cityclub.org. Today's forum is sponsored by the AIDS Task Force of Greater Cleveland and is also part of the City Club's Health Innovation Series sponsored by Medical Mutual. Our gratitude to each of these organizations for their continued support of the City Club. We would also like to welcome guests at the tables hosted by the AIDS Funding Collaborative, the AIDS Task Force of Greater Cleveland, the Cuyahoga County Board of Health, and the Center for Community Solutions. Thank you all for being here. This Friday, the City Club will close out 2024 with a conversation with Connie Hill Johnson and Kevin Johnson and celebrate the soul of entrepreneurship and community leadership. You can learn more about this forum and others at cityclub.org. And that brings us to the end of today's forum. Thank you once again to our panelists. I'm Ken Schneck, and this forum is now adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.
Production and distribution of City Club forums on IdeaStream Public Media are made possible by PNC and the United Black Fund of Greater Cleveland, Incorporated.